Hello, everyone. We're letting people in from the waiting room. While we do that, just going to run through, if you've joined us before, run through a little bit of a background on our Ability Grand Rounds. Want to welcome you to our April Ability Grand Rounds. This is a Grand Rounds series from West Virginia University Center for Excellence in Disabilities. And we appreciate you joining us today. Just to kind of, let me move screens real quick. All right, this tells you a little bit about this series where we have the privilege to invite our colleagues statewide, regionally, nationally, and even internationally during this series this year to share their research, services, and training efforts that have been published in peer-reviewed journals and other outlets. So we're able to learn from one another in this series, which is always a great thing. Before we get started, I just want to remind everyone to mute your line, but having said that, I want to really encourage discussion and questions after the presentation, or even use the chat function. We love that. And to practice, if everyone can start by putting your name and telling us a little bit about yourself. Where are you from? What's your affiliation? Let us know that. That's nice to see as we get going. If you're comfortable, I see some people using their cameras. Thank you so much. That adds a friendly atmosphere. We know we're not just talking to names, so thank you. If you're not comfortable, we totally understand that though. And then lastly, again, if you have a question, raise your hand. If you want to give response, thumbs up. Reactions are always great, or you can always put it in the chat. After our presenter finishes with her slides, we are going to have time for questions and answers as well. So with that, and thanks to everyone for putting your information in the chat. All right, so on to the most important part. Let me introduce our presenter. So Dr. Grace Brannon is an assistant professor in the Department of Communication at the University of Texas at Arlington. I was asking her about the weather before we got started, and it's very different than here. So it's nice and warm. But almost too warm sometimes, right? So she earned her doctorate, her PhD at Texas A&M University. Her research focuses on how communication is central to achieving positive health outcomes and mitigating negative health outcomes using mixed and innovative methods, which we're going to hear a little bit about from her presentation today. Her research is centered around understanding and improving patient and the patient's family's experience, particularly for marginalized populations facing long-term health issues. Much of her work focuses on developing pilot-tested materials leading towards larger-scale intervention implementation, and perhaps we might be interested in applying it to some of our work here in West Virginia. Who knows? She uses mixed methods approaches, including secondary data analysis, focus groups, interviews, and surveys. Dr. Brannon has received funding from the Health Resources Services Administration, or HRSA, American Institute of Cancer Research, and the CDC. She has over 25 publications in peer-reviewed journal articles and book chapters. Dr. Brannon, I'll turn it over to you if you want to share your slides, and thank you so much for joining us.
All right, thank you so much for having me. So yes, I'm very excited to be here. And I think the first thing I want to do is kind of highlight some of my personal experience. So before I get into a little bit of situating that this is a research area, I wanted to highlight an interaction I had in February. So my son, I have a set of twins and then a younger kid as well. So the twins are 5, the baby is almost 3. And I took the son to go to the audiologist. He's had a series of failed hearing screens and he's already visually impaired. So this is kind of a really touch and go type of thing. He had, he's totally blind in his right side. And I had gone through the entire health history with surgical history and everything with the provider. We go into the audiology booth and then the provider comes back out and immediately puts the probe in his ear on his blind side. So he didn't see her coming. And of course he's scared, he jumps, and then doesn't want to help and participate at all in his hearing screen. So needless to say, really frustrating experience. And so this just highlights again how important it is to have patient and family-centered communication. And so I was able to talk with a provider like, hey, this is what's going on. I need to call out this behavior because this isn't just my son at that point and his interactions with healthcare, but now he might be more afraid to go to the audiologist again. We're going to have continual hearing screens over the next few months. But this was at a children's clinic. And so if we're having these types of interactions at children's clinics with people who are supposed to be trained like that, what else might be going on? So I was able to have a productive conversation after that, but just recognizing that this is something that's happening very regularly, all too much, and can be really frustrating and hurtful for both the patients and the families. So I wanted to highlight a little bit of other things on my background too. So I was actually diagnosed with type 1 diabetes in 2011. So while I am interested in the academic side of things, I also have a personal vested interest in disability communication. So looking at how disability disclosures in the workplace are done, how we talk about our health issues with other people at work to seek social support, informal support, or even the formal disability accommodations. So I was diagnosed as an adult, and so that affected some things. We're not going to talk too much about diabetes specifically today, but that is an area of research that I can answer questions about too. So I also have experience from the family viewpoint, so specifically advocacy. So one of the twins was born with a really rare genetic mutation, which we were able to receive the official clinical variant of known significance diagnosis earlier this year. So for the first 5 years, it was just a variant of unknown significance. We've gone through a series of genetic studies, even visiting the NIH this past year. And so we were able to get that documented clinically, which was really nice. But that has led to several different therapies and such through that. So, and across different counties as we've moved and so on and so forth. The same child, unfortunately, also had experience in a hypoxic ischemic encephalopathic event at birth. And so we've had a series of subsequent therapies there too. So I have lots of experience from both the professional side, but all of these types of experiences have actually really influenced me to look at the family-centered aspect of it, because the advocacy part related to receiving surgeries, occupational therapy, vision therapy, going through the ARD process, et cetera, was really, really foreign to me. So again, I was diagnosed with my health issues as an adult, and so didn't have to go through any ARDs or anything like that. So that's that. So we know that children with special care needs often face higher risk than their healthy peers if they do not access care, which can result in delayed diagnosis, late treatment, and even death. And so I want to highlight the importance of communication in this. So it's not just the interactions between the patients and the providers, but also the families too, because especially for pediatric patients, the families are really the ones who are able to bring them to the appointments, to engage with them, to help them adhere to whatever medication routines or glasses wearing routines or whatever it may be. And we know that PCC can affect health outcomes. So PCC being patient-centered communication. And that would involve, do providers listen carefully? Do they explain things? Do they show respect? And do they spend enough time? And so these are 4 different factors that are used on a lot of nationally representative surveys. So the Medical Expenditure Panel Survey is one that I'll talk about, and then the National Survey of Children's Health. And so these are all just different ways to look at patient-centered communication. And so if these breakdowns happen, then that can cause distress and then worsen patient experiences like the one I talked about early on. And so I can talk about how anecdotally in that interaction, the provider didn't listen carefully. They maybe were explaining things well, but I didn't feel that they showed respect. And then maybe there wasn't enough time spent going through the medical history. And so the patient, my son's experiences were more negative because of that result. And so I know it's a lot of words, but we are recording, so you'll be able to go back and look at this at any point. And I'm also happy to share my slides. So this study that I'm going to be talking about first is, and I have a second one if we have time, but this first one is from a paper that was published last year. And in this, we were really focused on how we were receiving healthcare due to COVID-19. So it disrupted a lot of ways that we receive healthcare. So the preventive cautions, so like moving healthcare services online, that were taken in the earliest months of the pandemic to help mitigate risk for vulnerable populations, including children or people with chronic conditions, contributed to many people foregoing or delaying healthcare entirely. And so previous research we noted related to needed and not received care, and it was mostly focused on specialized care. So like cancer care, diabetes care, but we wanted to highlight how children with special care needs may face higher risk than their healthy peers if they don't receive that care access. And so we talked, of course, about the strict lockdown measures depending on your geographical region and people's hospital avoidance during the pandemic, along with limits on healthcare provider services, were, of course, some of those factors. So before the pandemic, researchers had talked about like non-modifiable factors like demographic background, insurance coverage, education. And so we know that people with lower education levels tend to forego healthcare at increased rates than their higher educated counterparts. However, we know that non-modifiable risk factors can not really be easily changed, but we know that modifiable factors can be. And so this is where we're trying to plan interventions to help improve conditions of populations facing disadvantaged things. So this might include the communication environment, influencing the usability of healthcare, possibly even facilitating medical participation of, say, children with autism spectrum disorders, so to decrease their unmet healthcare needs and foregone care. And so in the pediatric context, previous literature has highlighted how two communication factors, so family-centered communication, like patient and family-centered care, and shared decision-making were associated with efficient use of healthcare services. And so there's some citations, Fix et al. In 2015 and Kulthau et al. In 2011 that looked at those things. So for example, there's a patient portal intervention that facilitated shared decision-making in pediatric asthma care, and that helped improve parents' communication with their providers and their awareness of adherence to treatment. And we also see some review studies that have found positive associations of family-centered care with improved access to care and efficient use of healthcare services. Yet, of course, COVID-19 comes in and that presents all sorts of challenges because, limited presence of families in healthcare settings, because we're trying to reduce these spread of COVID-19. And so as a result, we identified a need for further explanation of how to maintain that coordination and continuity of care for pediatric patients in light of pandemic disruptions. And so I really wanted to focus on the collaborative and family-centered approach to improve those medical outcomes. So we ended up looking at the framework of collaborative decision-making, specifically, again, that family-centered care and shared decision-making. So we will look at the pathways in this, and we also wanted to highlight the importance of mental health needs and then those with physical health conditions also, and looking at those a little bit separately. And so again, FCC being family-centered care, so looking at both the patient and the family's perspectives, thinking about when these surveys are being done, it's not the children, it's not the patients themselves who are being surveyed, it's actually the parents. And so it's the parents' perceptions of the care and the communication that the child and the parent are receiving. And then shared decision-making. So these were our hypotheses, and then I'll show a model that looks a little bit better, but we really wanted to focus on open family communication. So how well does a family communicate within itself? And then how well does that maybe relate with the foregone pediatric care? And then how might this differ by family-centered communication and shared decision-making? And then also parent satisfaction with providers' communication. So this was our pretty model there, our theoretical framework. So we use data from the National Survey of Children's Health. So the NSCH is a It's funded and collected by the Health Resources and Services Administration, the Maternal and Child Health Bureau. This particular data set was collected between July 27th and 2020 and January 22nd in 2021. So it used an address-based sample from administrative records. And the NSCH invited adults of U.S. households that have children under the age of 18. The invitation was actually mailed out, and adult participants completed either the paper or an online questionnaire. So the link was also sent that way about their child's health. And then if a household had more than one child, only one was randomly selected as the subject of the survey. So there was about a 42% response rate, 42,700 something surveys were collected, and about 600 to 3,000 completed per state. And so each participant was randomly rewarded nothing, $2 or $5. As NSCH that year was running an experimental incentive program to increase the response rate. So for this particular study, though, we used the data from 10,845 parents of children who completed the NSCH survey and had visited a doctor or made any medical decisions within the past 12 months. And so our descriptive analyses here. So looking at the average age of the children, not the participants, obviously, insurance, so on and so forth. So some descriptive analyses related to gender or sex, race, foregone care, whether or not they had anxiety, depression, diabetes, asthma, epilepsy, and heart conditions. So the reason why we picked these specific conditions was because these are ones that tend to be more similar in the way that they present. So like we can categorize mental anxiety and depression kind of similarly, as well as like diabetes, epilepsy, heart conditions, asthma, because they require a lot of regular care. And so there were some other conditions that were being measured in the NSCH data that we did not opt to use because they didn't necessarily fit the like regular structure of care. So like with diabetes often has a medication, asthma, you often have an inhaler, maybe allergy injections that you do as well, epilepsy, certain medications, heart conditions, same thing. So that's why we picked these. Happy to talk about these more too at any point. So looking again, we wanted to also look at child's insurance coverage, health status overall, and family income. And we also looked at health insurance was asking how often the child's health insurance offers benefits or covers services that meet the child's needs. And this was measured on a 1 to 4 scale. So 1 being never and 4 being always. And it was the mean was 3.46. And so that meant the majority of participants felt that their children's healthcare needs were typically met. And so we conducted mediation analysis through SPS's macro, and we wanted to look at physical and mental health conditions separately, not only because of our own personal vested interest, but there is actually research that has done this in the past too, Jackson et al. In 2019. So I have these here. We don't have to go through all of these, but I wanted these to be able to be seen if someone wanted to go back and look at them later on the recording. So predictors of foregone healthcare included younger age of the child, being non-white, having poor insurance coverage, having less open communication within families, and lower satisfaction with providers' communication. And so this demonstrates the importance of really social determinants of health. And so there are people who don't have quality insurance coverage. They're more likely to just not have that better communication. It might be for several different reasons, which we'll get into later. And then predictors of foregone care included lower shared decision-making, young age, and being non-white also. So looking at, sorry, for the first model being family-centered care and the second being shared decision-making. And then we also saw that better family-centered care and being female were significant predictors of open communication in the family. And so if parents, specifically moms, are seeing more family-centered care, then they're more likely to have open communication within their family about that. And so the healthcare interactions are kind of almost potentially bleeding over into the actual home. So better insurance, better family-centered care, predicted provider communication satisfaction. And so it could be potentially that having better insurance means you have better access to like better healthcare providers and therefore being able to maybe have more time spent with you and so on and so forth. So let's see, more shared decision-making and being female again, predicted open communication in the family, more shared decision-making, being female and having better insurance, predicted provider communication satisfaction. So we evaluated the patient family-centered care quality using specifically looking at things by health condition. We didn't have any significant findings, but when we broke that apart by each condition specifically, we saw that parents of children with developmental delays had lower odds of reporting their healthcare provider. And so this was somewhat separate. And so we kind of did like a post hoc analysis to look and see, well, we're not seeing anything with these like regular care things, but that are conditions that need regular healthcare, like with medication necessarily, but with developmental delays. That was interesting. And so we can see that some of the key factors here were having less shared decision making. So parents not perceiving that they were able to have the shared decision making with their children and the providers, and then lower provider communication satisfaction being associated with foregone care. And so this was happening with both children who had physical health conditions and also mental health issues. And so we suggest, based on these findings, that children with mental health conditions, the number has increased because for a variety of reasons, but maybe lack of social interaction, increased family stress, perhaps more adverse childhood experiences. And so, but these have increased the frequency of foregone healthcare, as well as, so they're missing more appointments, they're perhaps behind on vaccination schedules, not able to receive the preventive care they need, not able to catch problems as early as possible. So they also see lower family-centered care, lower shared decision-making, and less open communication and decreased satisfaction compared to children with physical conditions, when again, these were kind of broken down. So children's perspective in pediatric care should be prioritized. So there's been and I'm sure many of y'all know this, but there's been a push to really involve children in their decision-making practices. And so I can attest to that anecdotally again with the way that my children's healthcare experiences are set up. Their pediatrician does a really good job trying to bring in not just my opinions and stuff, but involving and she will ask them different things like, what's your favorite fruit and veggie? Do you wear your helmet? Blah, blah, blah. And so it's been really heartening to see that because I can reflect back on my experiences when I was a child and the pediatrician didn't talk to me. It was always to my parents. And so, and she's even prefaced like in the next 10 years, your role in these interactions is going to diminish and start diminishing pretty quickly to the point where we'll be asking you to leave the room by the time they're like 11 or 12 for a short period of time. And I was like, oh my gosh, this is cool, because then their perspective in this care can be prioritized. And so as researchers, one of the things we have to do is pay attention to these non-modifiable factors, especially if we're looking at potentially adverse childhood experiences or social determinants of health, and looking at how maybe we can mitigate some of the issues caused by lack of health insurance and geographical regions, so on. And so this was a nationally representative survey. So yay, that's always nice to see. And of course, limitation using secondary data, causality cannot be determined, lots of single item measurements. So one of the recommendations that we had, so while we didn't find anything specifically in shared decision-making or family-centered care by race or ethnicity, in general, we know that BIPOC patients report worse patient-provider communication and especially lower shared decision-making. And so BIPOC children are really disproportionately negatively affected within the mental health context, according to Hodgkinson et al. In 2017. So future research really should focus on assessing these populations' access to quality and equitable healthcare. So previous research also has assessed family-centered communication as a dichotomous variable, but it doesn't allow us, and so basically like, did the providers provide family-centered care? Yes or no, versus looking at each one of these variables individually. So did they listen? Did they spend enough time? Did they show respect, explain things? And so being able to say yes, no, yes, no, yes, no on each of those things. And so future research should investigate these communicative domains separately. What is interesting is I have used some other data sets, also specifically the HINTS, the Health Information National Trends Survey. And that one, patient-centered care, doesn't usually work out quite the way that you would expect it to, but they have different questions that they ask. It's assessing the same construct, but the way that they ask the questions is a little bit different. And so we are recommending that future research could look at how these communication domains maybe differ across these different data sets. It's interesting why it works sometimes over here and then doesn't work over here. So given the context of the National Survey of Children's Health, the NSCH data, with a focus on children's health outcomes, we recommend adopting measures that can attend to the complexities of patient, family, practitioner. And so the item shared decision-making right now, does it truly measure shared decision-making, since it's only asking the parent's perception of that? It's not asking the child to take the survey as well. And so we're recommending future research involving the pediatric patients as well as patients and the parents and family member, other family members, maybe guardians, and then the providers. So that way we can get the perspectives of the entire triad or more who is engaged in the care. And we're also theoretically looking at Street's ecological model, which indicated an increased focus should be on the influence of these everyday interpersonal interactions. So we know that the majority of health communication really happens outside the clinical context. And so, yes, we're getting information about our health condition. Maybe we're getting recommendations on how to take medication at the physician's office, but really most of our health interaction is done on the day-to-day at home. The reinforcement of our norms about whether or not we go to the dentist or go to the provider is really reiterated through the family and from perhaps birth. And so if you're growing up hearing like, oh, we just don't go to the dentist, maybe we don't have health insurance, it's not something that our family does, then that can affect health outcomes later in life. And so the way that we recommend this is that practitioners have to work to establish practices engaging in the patient's parents, like the parents or guardians of children, in opening these regular conversations with children about health conditions. And so I can say, like, that is hard to do sometimes when they ask hard questions, and it will depend, of course, by the health condition that a child has. So if a child has cancer, that's going to be a harder conversation totally than if they have a visual impairment. So my son, like I said, totally blind in one eye, legally blind in the other eye. And he has asked before, like, well, how come I wear glasses and his twin does not? Or why do I have bad eyes? Someone at school told me I had bad eyes. And it's like, well, yeah, you clinically, like, you have bad eyes, but how can we maybe like talk about everybody has different needs? Some people need glasses, some people use a cane, some people use a wheelchair, just they're different devices. I use an insulin pump. And so how do we frame these things and open up this conversation? And there was one maybe a month or two ago, and he asked, what is it like to see with both eyes? And I was like, that's a good question. And I had to cover my eye, and I was like, okay, well, let's think about, being able to turn your head this whole way and seeing that without having to turn your head. And he was like, oh, wow, like you can see so much. And I was like, yes, I can. And just recognizing that is not how everybody lives their life, and being able to have that moment to kind of reflect and then work through that with a child. And those conversations can be really hard, especially for families who maybe don't have the health literacy to know how to manage those conversations. And so I recommend creating maybe age-appropriate handouts for patients and parents with maybe conversation starters or tips that would eventually lead up to like, kid, how do you want to be involved in your care? And so I'm not going to ask my 5-year-old that at this point, but it's like, well, do you want to do your eye drops? Do you want to ask the doctor any questions? Do you want to just being able to kind of encourage them to take some ownership over their health care? So that way we can allow parents and children to really be more attuned to the patient's needs and also the patient's wants, in efforts to, of course, improve health outcomes and ultimately decrease instances of foregone care. And so we also know like pediatric care encounters are not the only way health services are sought. And so it's important to consider other linkages. So like school and how they engage in care in the educational setting as well, because they will probably, I mean, mine see the nurse probably every month. And so where those conversations can be developed as well too. And our final recommendation is developing methods to collect perspectives, again, from the child's perspective, and that may change as they age. And I know I talked about that a little, but they probably aren't going to be able to do surveys. And so that involves a lot of parent interaction or guardian interaction too, because then you're having to get IRB approval from the parent and informed consent from the parent. So this is the paper from the data that I just went over, but I wanted to open up for any questions at this point or discussion points. And then depending on that, then we can move into the next one or see how things go.
That sounds good. So does anyone have any comments, or again, feel free to put it in the chat or go ahead and raise your hand and go off mute. Dr. Brannon, I do have a question as people think about their questions. You had mentioned majority of health communication happens outside of the clinic, and you gave a couple of lists. So either as you're going into the second story or just on the side for later, I want to know like how, and you listed a few ways, but how can we take advantage of that time outside of the clinic and enhance that communication if we're not the clinician, or if we are the clinician, right? Like 15 minutes to see this. How do we properly utilize that time outside of the clinic if that's where it happens?
That's a really good question. So if you're the clinician, I think probably the biggest recommendation would be careful with the nonverbals and just kind of pay attention to those, because I've noticed that some providers are like, oh, well, what questions do you have? Or do you have any questions for me? But they're saying that as they're walking out the door. And so some providers may not realize that they're basically nonverbally saying, do you have any questions? But this is just like just a cover up because I'm on my way out. So bye. And so a lot of patients actually do what are called like these doorknob disclosures. And so they wait and kind of until the very end to say the thing that's most important to them, which is kind of frustrating on the clinician side, but it is how things happen a lot of times. So on the patient side, being able to say, all right, or the family or the advocate side, what are kind of the top 3 things that you're wanting to get out of this encounter, and having those questions written down already. So 1, you don't forget, and 2, you make sure that those things are addressed, because clinicians' time is so valuable. It is so important. It's a very short window of time, and oftentimes they're rushed because they're overworked. They're maybe the last patient took way longer than they expected to, or was really late or something like that. And so it's not to say, I'm not trying to say that providers are doing this on purpose. It's just kind of like the byproduct of maybe a bunch of other competing demands and discourses happening. So I would say for clinicians, just pay attention to nonverbals and be willing to ask probing questions would be another one. So like, yes, mom or dad says something, and then you can turn to the child and be like, well, what else would you like to add? And then maybe trying to get them to start engaging in that care. Another tip for parents would be like, start having your child practice their voice. And so I'm using that kind of in quotations, but like have them order if possible. And I know this is not possible for non-speaking children, but maybe even like typing up their order for something if you're going out to eat, or having them practice ordering the ice cream at Brahms. And so that's been one thing two of my 3 children have gone through speech therapy. And so this has been a really big, like, we have to practice speaking. We have to do this because you're not going to get better if we don't use these skills that we're learning. And so even just knowing that the person on the other side of the ice cream counter, they will not understand a word this kid is saying, but lifting them up and being like, all right, say your order, and then I'll translate after. But that way they're getting that practice and that skill starting to develop in a low risk situation. So right now it's ice cream, but later on it could be an STI diagnosis or something major. And that could be really, really important. Let's see, I'm trying to think what else. So for clinicians, yes, nonverbals, following up with probing questions. I think those would be probably my top 2 things there. And then for parents, advocates, guardians, really trying to create those routines where the children can practice being engaged in those conversations.
Perfect. Thank you.
Yeah. Okay. So the second part of the study looked at patient and family-centered care from the framework. And this particular project was I was partnered with someone in public health. And so this is more of like a bigger picture thing than the other one, which was very much more like communication centered, theory centered. And so really a child's primary source of strength and support in managing their care is family. And this goes back again to the majority of healthcare routines that happen. So for example, I had type 1 diabetes, all my insulin pump changes, all my glucose management, all of my medication, talking about with Express Scripts or whatever, all of that happens on my time outside the clinic. The only thing that happens 4 times a year is twice a year I do lab work, but then 4 times a year I meet with the endo and talk through some of these things, maybe make a few adjustments, and that's it. So type 1 diabetes though is like around the clock management. It doesn't stop when I go to bed, and it doesn't stop when I wake up, and it doesn't, like, it's always going. And so in the same way, the family is affected by these types of health conditions too. And the child may or may not know how to manage the stress that comes with it, or even depending on the condition, how to manage the condition itself. And so the family is really the biggest source of support and strength in these. And so we're looking at, again, parents or families who have children who have developmental and chronic health conditions, and those do not. And in this study, we wanted to focus on mothers, because a lot of the research looking at patient family-centered care, it's typically a mom who takes the child to health encounters. And so it's not usually, if it's a heterosexual couple, it's not usually the dad, although in some cases there are, but it tends to be the mom is the one who takes kids to the appointment, knows their birth, date of birth, and all that stuff. In fact, I've seen Instagram reels about it, so it's apparently very common anecdotally too. So in this particular study, we were looking to examine mothers' perceptions of healthcare providers' practice of PFCC, and then also look at associations with those. So kind of similar, but just again, looking at specifically at mothers. And so this used pre-COVID-19 data. So medical expenditure panel survey, looking at the household and medical condition data. There's lots of different files that you can pull from. And these are both, by the way, publicly available. So anybody can actually request these and download them and then run their own analyses. So in the last one, we used SPSS to run the analyses. And in this one, we used data. So but you can download the data files in anyway. There are some not medical expenditure panel survey, but the National Health Information Survey, the NHIS data set, some of those are restricted. And so you would have to apply and get permission for that. Same thing with, there's another data set that's restricted. But for the most part, these anybody can download. So similar to the last one, we looked at parents who had children who had visited a healthcare provider in the last year. That way they weren't trying to think back to something that had happened 5 years ago or something like that. And then there was a total of about 36,700-ish people, and then mothers were about 86% of that. And so that ended up giving us our 31,000. And so we looked at whether or not they had developmental or chronic health conditions. And then we looked at the separate domains. So listen carefully, explain things, show respect, spend enough time. And then we did the recoding to the always or not always. And so basically, if they always did those things, then it was an always, but if it was never, sometimes, or usually, then it would go into the not always. And then we used STATA. And so we can see here that among mothers whose child had a health condition, we can see that showing respect is the highest one that happened all the time, but time was the lowest. And so explaining things happening all the time happened only about 83%, among 83% of them, and then only about 81% said that they listened carefully. And then we have our odds ratios and confidence intervals here, if anyone is curious. But in this one, we wanted to highlight that healthcare providers really do have to be trained to establish these high quality practices, because we're not seeing that many parents are experiencing these things all the time. And really, we want them to be experiencing these things all the time. Like, are they listening? Are they, because we know that it can affect their foregone care, like whether or not they'll actually go and get care. Maybe it's less important if they're getting care with that same provider, but some are having one poor interaction and then skipping healthcare altogether. And so one of the conclusions too is to, related to this conclusion, I teach at a four-year higher ed institution, and we have kind of a pre-med, like we don't have a formal pre-med program specifically. We have a lot of people who are basically pre-med though, and they're working on maybe a biology degree or a physics degree or something, and to translate that into whatever specialty they want. And we're seeing that their degree plans are really, really tight. There's not any extra room really for these like soft skill building courses, but we know how important it is. And so being able to get boards of regents of higher ed institutions to allow these students the space to start building these skills at the undergraduate level can help build that foundation earlier on, rather than waiting until they're working in their medical program. Because if they wait, then they've lost out on 4 or 5 years to practice those skills. And by the time they're an intern or a resident, that can really complicate how they're having those interactions, especially as the stakes just get higher and higher when you're worried about placement and where you end up and everything like that. And so we recommend that this training start happening earlier. So maybe not necessarily high school, because not everyone realizes, how important things are in high school, but definitely in college. And so there's been a push at some institutions to start these medical humanities programs. And so being able to have these conversations about the ethics of things is one focus, but really communicating about health and culture, or health and health disparities and equity, is really, really important to being able to improve these health outcomes. So we recommend, okay, we need to, for future steps, be able to adjust for different child and parent characteristics, but we also want to link to the NHIS data, which we ended up doing in a later study. But MEPS data sources doesn't include a ton of different types of health conditions, but NHIS does. And so being able to link parents and children from these different data sets can be done. The issue with this is that you have to do it at a data center. So I live in the Dallas-Fort Worth area, and there is actually the Census Bureau's DFW Regional Data Statistical Resource Center, something like that. And you have to get background checked and basically become almost like a contractor for the Department of Commerce to be able to access these types of things, fingerprinted and all that. And so I think it's maybe 5 or 6 trainings a year you have to go through. It's a pretty involved process to be able to get access to this data. But we can see different historical trends and prevalence. And I think going over the next couple of years, as the post-COVID-19 height of the pandemic data is really coming out, we'll be able to see kind of the pre-COVID trends and then what's happening now as we're moving into the endemic phase of COVID-19. So that's something that we're recommending and we're actually working on doing now. So we were Dr. Kendrat, who again is in public health, and I have just gotten approval in the last month or so to start working on kind of the next phase of this project. It's just a long, time-consuming process, and it's a lot of paperwork too. And so I wanted to highlight her Human Services Research Lab here. And then these were our wonderful students who partnered with us on this. And so Maddie Ray is working on a doctoral program right now, which is super, super cool, health communication. And Peyton Lark is an EMT. And so we've had some cool students come in and work with us on these projects here. So yeah, that's kind of it for that study. Any questions there?
Okay, I don't mean to monopolize, but I do have a question related to this.
Yeah.
So you said early, get to providers or student learners early, absolutely.
Yep.
What, are you finding anything from the sources that you're reviewing for residents? So they're already there. Their events don't seem to be structured, which makes them particularly a harder group.
Mm-hmm.
On the graduate medical side?
I haven't looked into the graduate medical side. It's so far removed from where I currently am right now that is a really hard population for me to access if I wanted to do anything kind of in-house. But it is an area of interest because especially we're going to be looking at kind of like an educational gap between those who were in school and had graduated pre-2019, 2020, when COVID-19 really hit and we shifted to online. Because I know like our nursing students here, they were doing all their labs and all their practicum like online. So they were doing like their tours of nursing facilities and stuff. And when they should have been in hospitals online. And that was just how it was for a whole year and a half. And so we're seeing quite a few people who are in the graduate programs now whose undergraduate education was maybe partially or primarily all online without those soft skill interactions. And so I think they're actually a very vulnerable population to this right now and need that extra work. But so many people are focusing on, we got to get them caught up to being able to do the hard skills, the math and the science, and being able to know the A&P, whatever things, where that's kind of actually getting more ignored than it was before. And so we're kind of in this like, it needs to be more of a focus, but they're also just trying to support them where they are. And yeah, there's a lot of needs and not enough time.
And I guess I'm going to throw this one out to you as well as people that I see on here. So I know we have several initiatives that many people on here are working on with health providers from the family perspective where the families are mentors. So there's an overlap there. Maybe they would want to share some of that.
That'd be awesome.
But those tend to be, like you've mentioned them, first impressions. You mentioned it with your son, don't come at him when he can't see. I told him,
Right.
those types of approaches that they should know about. So the question to you and the whole group is, let's say we're able to reach everyone with those key initial pieces. Where else would you all want to go? What other pieces beyond first impressions and considering the patient experience, what other areas would you like to get to?
It's a great question. And I'd love to hear from someone who's not me, if possible. But
Anyone? Put you all on the spot. I'm going to put Maddie on the spot. I think and our AT, but I'm biased. I think assistive technology goes under the radar a lot, and could utilize that far more, educate people on that a little bit more. But it doesn't quite make it into our education, at least initially. in that sense.
Yeah. Well, and I know one of our things also, we had recommended, using my chart and stuff can help kind of bridge that gap and allow some more, it's more accessible communication for the parent. Like it can be asynchronous, you just think about it, drop your provider a line, but it still creates additional burden on the healthcare provider that maybe they're not always getting compensated for. And so that's kind of a concerning area too, that, as a parent, I don't necessarily want to be charged for just a quick question, but if the provider is getting 80 quick questions every day, that could be an hour and a half of their time added up. And so how we're going to be looking through that and thinking about that over the next few years. I'm really interested to see where that goes. But using telehealth as a way to kind of mitigate some of the foregone care is actually one of my areas of future, of ongoing research with Dr. Luna Wu, and who was co-author on that first study. Lots of promising things there.
We definitely want to check in with you. A lot of people are interested in telehealth on here.
I would be interested in learning more about interactions on mental health, the mental health side for our children. A lot of times the family's first interactions with children's mental health comes at their primary care when something is happening at school or at home, and I'd be interested in learning about the differences in excuse me, in care provided for different demographic groups, rural versus urban, white versus non-white, as it pertains to how quickly the views and ideas of the parent are taken into consideration and then medication prescribed. I mean, I see in my role, I see children who, according to the DSM-5, are being diagnosed with conditions that, according to the DSM, they should not be because of their age. And so they're getting diagnosed with these more adult psychiatric conditions and then being medicated. And sometimes it doesn't appear that there's very much assessment done to determine the validity of those psychiatric conditions. And so I would be really interested in learning more about or reading research. I can't do it myself, I don't think. To see what can be done in provider training, in parent training, in something so that our first impulse isn't just to give them medicine,
And it's really hard, especially thinking about like little kids too, and you're like, why are they behaving like this? And not taking it as a parent, not taking it as a reflection of your parenting, but trying to figure that. And so I know for a lot of parents, that's a really challenging thing to overcome, that maybe the parent doesn't even recognize as an issue. So one of the things I think is really important is, and this comes down to, like you said, the demographic, like maybe where they live, urban versus suburban. Right now we live in a highly urban area, like, so, well, I mean, I'm in a suburban area, but like adjacent to two urban areas. Our previous area was more rural. Like I lived in an unincorporated area. And so the ISD resources from schools to be able to partner with parents in getting kids evaluated is very different between these two things, and between these two counties where we have lived. And it has been definitely like the access to resources now is so much better than where I was before. And that is a huge problem because people, kind of self-select sometimes to where they want to live and work based on educational attainment and so on and so forth. So I'm trying to go back to your original question, but it is interesting to think about how each of these maybe potential demographic characteristics work together to influence the number of medications or the frequency of medication being kind of that first default thing, rather than trying to approach it from, let's try everything we can first before jumping into that, especially if someone is being maybe misdiagnosed or improperly diagnosed. And a lot of times the parents may not know because their own health literacy is probably not. And so they just trust whatever the provider says because the provider is the provider. They have the MD or the DO. They've got the certificate. They've got the diploma on the wall. And so that's a really interesting thing to think about. And if I have anything, I'll write your name down and send it to you. But it is really, really important to be looking at that, especially as we know, mental health issues are not disappearing. Like, we're seeing them diagnosed more frequently, which is, I think, personally a good thing, because then we're able to potentially treat them, but only if we're diagnosing correctly and hopefully the first time around. So thank you. Very thoughtful question.
Any other, I think we have some time for another question, comment before we go. All right. Well, Dr. Brannon, I appreciate your time, sharing your work. We want to check in with you and see what you find out. I love that you're looking at these larger databases too, because I'm really impressed at some of these. I didn't even know they had some of these variables in it. And so we're missing out that opportunity. So thank you.
You're welcome. And yes, if y'all want to know any of the other databases, happy to just send me an email with anything that you want, and I can send you the links to them. And they're really easy to access. Like the NSCH one, all you have to do is a test. Like, you'll give them credit if you use their data, and that's pretty much it. Not to use it for nefarious purposes and stuff, but
Not bad at all. Okay. Yeah, a lot of us are doing needs assessments. What area, what should we do? So that's
yeah. And being able to say this is nationally representative data, like this shows a huge need across the board, not even just for the state, or which you might be able to break it down by state. I don't think we've tried that yet, but yeah.
All right. Well, thank you again for sharing your expertise, and everyone, thank you for joining us. Let me know if you need a certificate of attendance. I put that in the chat, as well as the evaluation. Please let us know what you think, and everyone have a nice afternoon.
Yes, you too. Thank you.
Take care.